as I understand, I have to speak for 10 minutes, and will I be given a bell of at around 8 minutes or so? Some indication or somebody will just pop up in between that 8 minutes are over. I have to speak for 10 minutes, right? Okay, so we fix up this time. If okay with Dr. Suresh Damodaran, 8 plus 10, 8 plus 2.
Yeah,
Yes,
well,
yes,
whatever are, yeah,
yes,
no
yes,
problem.
yes.
Okay, so here I go with the permission of chairpersons. So we're going to talk about GLP-1RA versus SGLT2I inhibitors in primary prevention of CVD. Now, there is no conflict of interest for this particular talk. However, the agenda is here. See what CVD and its risk, primary prevention, what do we need to do? What are the various GLP-1RA molecules? Which aspect of CVD, which molecule does affect over there? A special category of metadata of primary prevention, which is not yet there in the articles published, but which we have dissected specially for this particular debate. I think that was one of the mottos to understand this particular science. What exactly happens with GLP-1RA versus SGLT2I guidelines from 2016 till 2021. And again, to show you with evidences that GLP-1RAs are stronger, robust, durable, better, and longer. Diabetes with chronic complications and implications, and we need to just not treat the diabetes as a value of a number of glucose. We need to get the complications under control, and there are various relationship between a lot of factors. So let me tell you at the outset that it is the kidney which also needs to be protected to also protect the heart. Number two, that the high risk, the moderate risk, as well as the mild risk, all people, those who are into this kind of risk category needs to be taken into consideration. And I'm sure that Dr. Suresh will show you some slides which he will say that the study did not have this kind of criteria. So I will show you the studies which had a very strict criteria also for primary prevention and broader range. So here I show one slide which talks about various GLP-1RA, and to state that Revine was the trial which had approximately 68 to 69% of participants which were having broad range of risk factors for primary prevention. This is one of the important study. Also, leader and sustain, as you move ahead, I'll show you what was the percentage of primary prevention in them and how much they fared better than their particular comparisons with placebo versus others. So these are some evidences where SGLT2 also has been shown to have comparison with primary prevention. And importantly, as we look over here, there were female participants which were more in the dulaglutide arm in Revine trial here, which is not there with SGLT2. So a broader range of sex, broader range of age, a worsening HbA1c, and pre-existing cardiovascular disease, which was out for many, but we have a lot of data, around 69% of population from Revine and various other populations from oral SEMA, injectable SEMA, and liraglutide. So this is what the parameters have an effect on A1C and on weight compared to others. It's a very simple graph showing, and I think this was one from the 70% of dulaglutide study that the 3P MACE was relatively reduced risk of 12% despite the majority of patients not having established CVD, meaning that most of them had a CV risk factor and they were treated. And as the data goes ahead, this shows that all the components of 3P MACE had reduction, and this study came out very positively for primary prevention. Apart from that, there are studies which I will show you now about. If you look at this graph, it looks like SGLT2 are the best in the MACE, but it's not like that. Let me show you the data on MACE, the primary risk factor prevention on MACE, and look at the enormity and robustness of the data when you add just one study. Here, this blue mark shows only the data from Revine compared to all other GLP. So if we add the primary prevention data from Sustain 6 of 20%, from a leader of around 20%, and from oral semaglutide studies, this arrow grows much bigger and bigger. And this data, my dear friend, is not really there for SGLT2. And if it is there, you look at the arrow, how small it is for just one particular thing of heart failure. But for MACE, there is no data of SGLT2. And if at all the data is upcoming, if Dr. Suresh shows you, it is not going to be as robust as the GLP-1RA. And I think this is first part of my talk where I show actually how there is an anti-atherosclerotic, anti-inflammatory, and the endothelial modulation which helps in protection of CVD with MACE. Now, he will talk about a lot of heart failure. Let me tell you when heart failure will happen in a diabetic cardiomyopathy. These are the risk factors. We are talking about primary prevention. So look at the dyslipidemia, hypertension, diabetes, obesity, and others. This is where we need to protect the patient first. LV remodeling may happen quite late. Symptomatic heart failure will happen quite late. In at least 90% of the patient, it is going to be just the control of myocardial infarction, the atherothrombosis, the ischemia, and the atherosclerosis. And this is what Ralph DeFronzo and similar co-authors have talked about, that this is what we need to harp upon in the initial years. Now I'll show you data which is not been published in all these studies, but we've dissected for this particular debate. The primary composite for leader, as shown here, is actually in favor of liraglutide. The particular lines in the gray that you see, we've dissected for only primary prevention data, only primary prevention population to show in this, and it does show that there is a benefit in occurrence of CV death, there is a benefit in non-fatal MI, and there is also benefit in non-fatal stroke, which talks about the primary prevention. Even in SUSTAIN 6, although it did take 60-70% of secondary established CVD, this data is about the primary prevention that we've dissected again, and it showed quite good amount of significance for protection of 17% of SUSTAIN 6 population over here. And in subject with CV risk factor, if you see here again the line how semaglutide protects the MACE, and it also protects to various other risk factors. And this is how is the modification of the risk in atherosclerosis, which is a direct effect of GLP-1RA, and not a single SGLT2 has this kind of action. And that is what makes GLP-1RA more robust and more good data. So data on all the four, as you see in the four blue arrows, is there. Effects on BP, weight, and A1C. And importantly, the lipid data that GLP-1 has is not seen with SGLT2. They do not have a favorable lipid profile, and that is what again makes it a better molecule for primary prevention of CVD risk factors in diabetes patients. And that's the reason even ADA 2021, just not a first thing which has happened now, it has been there past around 5 years that this molecule has been up. Now he will talk to you only about that this criteria was very broad in CVD. So let me tell you, the SUSTAIN, LEADER, and PIONEER studies, and the SOUL study, which is coming with oral semaglutide, has got very strict criteria about renal impairment, about the lower extremities, and vascular stenosis, which also talks about a very broad range of primary risk factors. This is what we were alluding to, that it has been now around more than half a decade that these molecules are shown to be beneficial in primary prevention with various bodies like ADA, EASD, RSSDI, and Diabetes India, wherein when you look at the data on atherosclerosis, these are completely better molecules. These are molecules to be used with additional risk factors who require glucose lowering therapy, initial lifestyle modification, and metformin, and it is completely reasonable to initiate these molecules. So there might be a tussle about oral versus injectable. So let me tell you, oral completely semaglutide is on the way, and we have studies, and we have there is a PIONEER study and SOUL study also comparing oral semaglutide with empagliflozin, wherein oral semaglutide was better. And there is also oral SEMA with a liraglutide trial, wherein again oral SEMA was better. So there is nothing like these are only injectable. That point is completely well taken. And this is how I think I would want to rest the case, and I want to finish well in time, that for primary prevention, what you need is reduction of risk factor, and there is a complete, robust, and stronger data for atherosclerosis, anti-inflammatory, and modulation of endothelium with GLP-1RAs. They decrease all the traditional risk factors of reduction in weight, better than SGLT2, reduction in HbA1c, 1.3 versus 0.8, better than SGLT2, reduction in systolic and diastolic blood pressure, and reduction and a favorable lipid profile, which the lipid profile effect is not there with SGLT2 at all. There are treatment options available which can be given just once a week. there is oral option available, and which is better than in recent studies compared to EMPA and LIRA. There are narrow as well as broad definition of CVD in primary prevention, and data with GLP-1RA is available. The longest study was 5.5 years long data we have, and these studies of GLP-1RA, one study has taken up to 45 to 50% of women. So we are sure that generally in CVD prevention, women participants are not there. So here we know that there's a stronger data there. There is an expanding indication for prevention and managing CVD with GLP-1RA in non-diabetics, in rheumatoid arthritis, in HIV, in other autoimmune diseases, including type 1 diabetes. And this is how these drugs are going to really take care in future once the oral series includes and comes completely into market. And if when we count heart failure as one of the issues for primary CVD risk prevention, then there are many options to treat heart failure, including there are a lot of options for diuretics. I think if we look at the primary prevention risk factors, the risk factor and primary prevention, that goes in favor of GLP-1RA. And with this particular line, I think I hand it over to chairpersons. Thank you so much.
Can you stop sharing the screen?
Yes, Doctor.
Is it visible?
Yes, you can start, sir.
Yeah. Good morning, everyone. Thank you very much for the wonderful opportunity, Diabetes India, and we had a wonderful evening last night as well. And it's nice to debate with my good friend Altamash. So I think in next 8 minutes or so, I have a responsibility to drive home the message that SGLT2 for primary prevention of cardiorenal events. See, the point is, the main point that we need to discuss is, the topic is SGLT2 or GLP-1 for primary prevention. It's not only for cardiovascular disease or 4 3-point MACE or anything like that. We are talking about a broader term, and we are talking about a primary prevention of cardiorenal events. So that is the topic. So just to remind you, so this is my agenda. So just introduce the SGLT2 and then why there is a need of primary cardiorenal protection. And I'll put you some practical case, because after all, the debates has to end up with some practical points. And SGLT2, what are the things available, and cardiorenal data that is available with SGLT2, and I summarize that. So if you look at the last half of the decade, there is more of a major complications like stroke, lower extremities, amputation, and end stage renal. That has been substantial increase in that. And the future is being darkened with the resurgence of vascular complications, and also evidence of heart failure, which has been missing in the previous talk. So if you look at the life expectancy, that has been almost declined since 2014, primarily because of cardiometabolic risk factors, and also the older people, especially the type 2s, are vulnerable for CVDs, and it is remaining a leading cause death globally. So that is the thing that we are talking about, and needs a major policy challenge for most of the countries. And a good friend was talking about MACE, but I think if you look at the estimated MACE, only 9% of the risk of estimated MACE is eliminated after achieving the best glycemic control. So if you do even a best glucocentric glycemic control in type 2, and the risk of heart failure is not influenced at all. And the evidence of concepts like the risk of vascular events is definitely persist in spite of intensive. That's why we see deaths even after the intensive glycemic control. So we know that type 2 diabetes is like a heart disease. We know that is historic, but I think the definition of secondary prevention usually refers to patient who suffers from previous acute ischemic event, where all the other categorized as a primary prevention. So this is the risk stratification. So very high risks are previous cerebrovascular event, and the high is clinical or instrumental evidence of CVD, and moderate high is multiple risk factors, and mild one is the 5 major variables. I think my friend is touch based upon this. So I'll put you in the practical case scenario that we face up in our clinic. So this is a 52-year-old man with metformin glycoside and a gliptin 8.2 A1C, and 66 of body weight, and there is no other comorbidities, whether family history of CVD, whether we should go for SGLT2 or GLP-1. I let the crowd decide. So the second case scenario is a 58-year-old type 2 being followed up as a master health checkup. She's currently on metformin and a sulfonylurea and A1C is 8 with a body weight of 60 kilograms. Would you start on a GLP-1? And that is the thing. So it's nice to see the data, but when it comes to practice, how you handle it. So again, a 47-year-old type 2 sales professional, metformin, sulfonylurea, and a gliptin, 8.7, and the body weight is 72 kilograms. Vildagliptin was stopped and liraglutide was initiated. There is GI symptoms. What would you do? So whether you continue with GLP-1 or switch to SGLT2. So just coming to SGLT2, this is the latest drug that is being talked about, and it's the drugs available. Most of you would know, and there are few drugs waiting to be approved. And India, remogliflozin has been approved as well. So there is growing indication of SGLT2. Where are we doing is like more of uncontrolled type 2. My friend was showing all the guidelines. If you see the first drug that is mentioned even before GLP-1 is SGLT2. So it has been widely used nowadays, and uncontrolled type 2, despite metformin, you can add on the indication of SGLT2 is growing. So why it is very important drug now with the current scenario with growing cardiovascular disease and the challenges what we face, because it's a mechanism, the cardioprotective mechanism. This drug is being taken up by even cardiologists nowadays, and it's being used as a drug as the whole approach to the vascular organ as a whole. So it decreases arrhythmia as an anti-inflammation, and also high EPO with oxygen delivery, interstitial fluid, this thing. And then from diabetes point of view, increase insulin sensitivity and adipokine regulation. And overall, there is a good response, a direct and indirect effect, as Dr. Altamash was mentioning. So there are good indirect effects with these drugs, along with the weight loss, which is obvious with these drugs. So, and how about the kidney? The kidney, there is renoprotective, there is a direct and indirect effect again. So directly the improves the GFR and it reduces the renal oxygen consumption, and then inflammation in kidneys also been reduced. Therefore, there is a good improvement in the blood sugar and blood glucose, and then uric acid level. You see it in the practical usage when you have a metabolic syndrome sort of patient coming in, and then with high uric acid and probably everything going out of the roof with BP and blood sugar, you will see the huge difference just primarily because of the action in the kidneys. So these are the broader terms that Dr. Altamash was showing about the GLP-1. But if you look at the broader term, this is the mechanism. There is specific effect for SGLT2, which makes completely different from GLP-1s, or the diuretic effect, natriuresis effect, and also the interstitial edema, EPO, erythropoiesis formation, and ketogenesis, which is good for the heart. And but if you look at the specific effect of GLP-1, he went through antioxidative, anti-inflammatory, anti-atherosclerotic, and albuminuria. So those are all there. But I think if you look at the common effects, these are all the common effects. But I think the specific effects is targeting kidney and heart will be there in SGLT2 inhibitors. So, and now I've spoke about the practical approach, how you approach, and then coming to the cardio-renal outcomes of the evidence what is available. So if you look at the RCTs and CVOTs has been done across cardiac and renal continuum, huge amount of data come in with all the group of drugs. Even ertogliflozin has come out with verticv. So Canvas is there, Declartimi, Emperor was there, which changed our practice. It's a and then Emperor and DAPA HF has come out. So, and then the Credence and DAPA CKD was published in last ADA. So the data is huge. So it touch based on mostly atherosclerosis, subacute MI, heart failure, albuminuria, microalbuminuria, end-stage kidney disease. Whole lot of things has been covered with SGLT2s. So if you look at the Dr. Altamash was showing about the primary prevention, which is there with dulaglutide. Completely agreed. But I think if you look at the numbers, the SGLT2 numbers for primary prevention, that is included, especially the declaratomy, it's a huge number of patients has been included as a primary prevention. That is the patients that you and me see in the daily clinic. So if you look at the overall benefit for okay, hospitalization, I'll finish off in a couple of slides. So overall benefit seen in hospitalization, it's been huge improvement in all the studies that has been done with SGLT2. So he mentioned about MACE. You can see the data that has been in front of you, and you can see the heart failure data. There is almost nothing for GLP-1, and then the DKD, almost nothing for GLP-1. So with that, I think you can easily say that the MACE, he showed this picture, but I think SGLT2 is better poised than GLP-1 for primary cardiac and renal protection. So with that, I stop by saying the management of type 2 has moved from a glucocentric approach, and we should look at the long-term benefit. That is the topic. You go for primary prevention, a non-glycemic benefit, and you have to get buy one, get 5 free. And that happens with SGLT2 with extremely good data. It is not like without the data. We are talking about drugs that is going to come in the pipeline, but I think we need to understand for practically now, it is only the oral GLP is not available. SGLT2 is available, and the GLP-1 has got definitely a terrible GI side effect, which everyone will agree who uses in our practical testing. So I stop by saying for primary prevention, for cardiac and renal, SGLT2 are the best evidence available now and best practical experience we got now. Thank you.
Dr. Altamash, you are on mute. You need to unmute.
Please allow me to share my slide, the rebuttal slide, with the permission of the chair.
You can share, sir.
So I think very elegantly he did talk about the cardiorenal, and I did show you first 3 slides of my talk about the kidney, wherein the data was shown and how important it is to get both cardio as well as renal factors down. Number 1. I think very importantly, he also misguided everybody by showing 3 cases, and the 3rd case was completely misguiding. The patient will come back with nausea, vomiting after 2 weeks. I think the education of the patient is very important over here. We need to start with low dose, stay low, and only when the patient is tolerating, we increase the doses of GLP-1 RA. And also, patients do come back within 2 weeks or 3 weeks. In fact, some patients call in 2 days also with SGLT2 eyes. I think that was a start note of it. So I'm just trying to give that as the first rebuttal, that patients on SGLT2 also do talk about side effects. They come with nocturia. Some people call and say that we got redness of our genitals. So I think this point is to be taken, and with a simple patient education, it does not matter that how much nausea you would get. In fact, it is the effect of the drug that you will get nausea, and you will not be allowed to eat automatically when you have that much amount of food. The second thing was my friend showed very glaringly that 58% of dapagliflozin. I again want to emphasize it to the audience and the esteemed chairpersons that Rewind trial dulaglutide was 69.5%. Now, if he has to show that dapagliflozin 59, I would definitely talk about 70% of Rewind, which is a more robust data, a broader and simpler important risk factors taken, 17% from leader and 20% from sustain, which actually had data. So if you look at only percentages, Canvas had 27% and DAPA had 59, but here we have 17, 20 and 70%, 70% from GLP-1 RA. So that is again important data in terms of numbers if you are believing that slide of his. Number 3, cardiologists are comfortable. They started writing GLP-1 RAs faster and better than even when the SGLT2 inhibitors came. So I think comfort-wise, we do not have an issue over there. Again, longer data. He did talk about only atherosclerosis, but endothelial modulation was completely missed out somewhere. And I think that is something very important to understand, that what effect this drug can give for cardio and renal protection combined. All SGLT2 together cannot give, because there is one meta-analysis which has compared all GLP-1 with all SGLT2, and there also the primary risk reduction of risk factor was stronger better and durable compared
2
to all
minutes.
SGLT2. I think these three are very important. And the last graph, what he showed, I'm done. I have covered the secondary prevention graph, but to mislead the audience, he again showed primary as well as secondary, wherein there were a lot of blue arrows for SGLT2. So the first slide of that main blue big arrow was only for the primary risk prevention for cardiac and renal. Over to chairpersons. Thank you.